talk by Professor Ashraf ARMIA, who is an internationally reputed cornea refractive surgeon, also has expertise in glaucoma. He comes all the way from Egypt, has been known to me for a long time, and we have had association also through Jerso, where he's very active in conducting very large-scale webinars. So we are very happy to have Professor Ashraf Armia, who is going to speak to us about cataract surgery, especially in eyes with keratoconus.
Good morning. Thanks, Valdemar, for the invitation. Thanks for the IOS. And this is my first time to India, to New Delhi, but not to India. I will give brief what I'm doing in my practice. I'm not going to take it theoretically. This is what I'm doing exactly. I'm working keratoconus, I think, since 22 years now, and we have a school also for training globally. I have no financial disclosure related to this presentation, but these are my disclosure to companies that I'm a consultant and speaker to them. So since in the last 5 years, a lot of changes happened, and we did a huge work with Cosimo Mazzotta. We published a lot of papers related to keratoconus to improve it. And lastly, we published, this is the new innovation for the ray tracing transepithelial excimer laser. It is going to change a lot of issues in refractive corneal surgery in keratoconus. And with the new machine, the IVIS, everything will going to be changes nowadays. And we are happy that this also was top-cited last month is with how early diagnosis with the corneal epithelial thickness mapping. This is a very nice publication, and I encourage everyone to read it. It's a very nice one. So let's start. As we know that cataract surgery in keratoconus is, the prevalence is more than other patients without keratoconus. And this is how the literature says. And this is my lighthouse for the cataract with keratoconus. In my opinion, after all these years, so you divide it into history of good corrected distant visual acuity, history flow, advanced. If it's manifest equal the topographic, you go for cataract with toric IOL. If the manifest is not matching with the topographic, you go for cataract monofocal, and if it's any residual, you can go for toric ICL. If it's the history of flow, so the irregular cornea, definitely don't go for cataract unless they make the cornea regular before you go for cataract surgery. So the challenging in cataract with keratoconus, 3, preoperative, postoperative, intraoperatively. And this is what I'm going to highlight in my presentation. So preoperatively, as I'm seeing all of my patients, that the challenges is astigmatism, stability, and IOL calculation. These are the 3 main challenges that facing any surgeon doing cataract with keratoconus. So why ectasia? If we think that progressive corneal ectasia, this is how the process goes. Myopia, irregular astigmatism, wide range of case values in a small area. This is the main problem in the calculation, changing in the anterior chamber without, which makes it more difficult to calculate the effective lens position. So if we think about keratoconus, it's like corneal ectasia is common, post-operative surgery ectasia resemble the keratoconus, and keratoconus resemble the corneal ectasia. All of them leads to IOL calculation problems. So stability is very important before you go for cataract with keratoconus. Calculate the lens when there is a confidence of corneal stability. Never calculate the lens in a fluctuating cornea. Advise patients with a small rex that decompensate the cornea, and we are going to highlight also that this is a common problem. And to have the stability, you need 3 pentacams, 3 different topographies in every 6 months, so 1 year and a half. Why there is a challenging in the biometry? Because the steepest cornea and the off-centered apex make it difficult to obtain accurate keratometric readings. Why? Because the aesthetic eyes have higher axial length and deeper anterior chamber. So this makes the effective lens position of the lens calculated will not going to be properly presented. As the apex is off-centered, it might not be the visual axis, and this means that the case is not the proper. So the accuracy, we started by the Barrett, and we worked with this for many years, but we found a lot of problems still. So after this, in 2019, came the another calculation and give this nice categories. They categorize the patient category 1, 2, 3, and 4 according to the corrected distant visual, and this is how we are going to do it now. But recently, after many formulas, Kane formulas nowadays came that it's the most acceptable biometric calculation in patients nowadays. And this is the most important formula that you are going to calculate your patient with keratoconus in cataract surgery. And this is the online calculator for the Kane formula. But they now we should advise that if you are going to use the Kane formula, use this. If it's stage 1, no adjustment. If it's around less than 50 or 48, 49, it's okay. But if it's you found the patient at stage 2, calculate the patient and leave the post-refractive residual spherical error minus 0.75 to up to minus 1.5. If it's advanced keratoconus, leave the patient with minus 2 to minus 3 acceptable, and never leave the patient hyperopic post-operatively in cataract with keratoconus. And if we are going to look for the astigmatism, if the patient is irregular astigmatism, we don't recommend for cataract with keratoconus to put a toric IOL, and you should do the astigmatic measurement for the patient with keratoconus with different machines to reach probably the proper axis and K1 for the patients. So the significant correlation between the total corneal astigmatism and the anterior corneal astigmatism and posterior corneal astigmatism is very important if you want to calculate the total corneal power astigmatism. So the use of toric IOL nowadays in cataract with keratoconus with low-grade astigmatism and regular corneas in keratoconus. Intraoperative tips, this is my tips. Early keratoconus, like normal cataract surgery. If it's severe keratoconus, so it is a trouble. Why trouble? Because the distortion of the vision. So when main incision is performed, it definitely changes the structure of the cornea. So according to the main incision, according to the where is the cone. This is very important. You choose superior or superior temporal if they have an inferior temporal cone. If it's a rare superiority in keratoconus, do it temporally. Cornea scarring is an issue in keratoconus, cornea keratoconus, so place 90 degrees apart from the cornea incision. This is important. Inferior scarring, so the superior approach is not advised because at the end of the phaco tip, we're reaching the opacity. Keratoconic corneas and thinner fropula, so also two steps cornea incision is crucial, and suturing for advanced keratoconus is very important. Diffuse scars, very important. That's worse under the surgical microscope. So putting different light sources is very important, and lighting from the side is good. And also spreading of the dispersive viscoelastic is crucial, like the methyl-cellulose, because it gives mild magnification and intraoperative intraocular viewer. Also staining of the capsule can help in the visualization in advanced keratoconus. In my opinion, whatever you do, toric IOLs, but narrowing the pupil is important, either by the IC8 from the IOL, or you do the pinhole pupilleplasty, as Ammar Gwaral mentioned in the last 2 years. I found in all my cases with advanced keratoconus, I do all the cases, even if I'm putting a toric, I do pinhole pupilleplasty if the patient around 2 to 3 millimeter post-operatively. Post-operatively two challenges, cornea ectasia, progression after cataract surgery, which is less common, but it can happen, and management of the residual refractive error. Why it happened? Because it triggered the cataract surgery, triggered the biomechanic stability of the cornea, and it caused mechanical stress. Also, cataract surgery can cause also surgical inflammation, and very rare cases it can cause to late progression ectasia. How to manage the residual refractive error? This is what I'm doing in my practice. If it's non-surgical option or surgical option. If it's non-surgical, if it's mild, spectacle is very nice tool for the patients. If it's higher astigmatism, rigid contact lens, because these patients are used to do rigid contact lens before. If it's options, two options. Either you do IOL exchange which is 26% of the patients we do this, or
Dr.
secondary IOL. And if it's secondary, additional toric IOL, as it mentioned, is a very good tool, and also the ICL for the high spherical post-operative results is good tool for correction of the residual post-operative astigmatism. So my take-home message, in keratoconic eyes, optimizing the IOL power calculation is certainly vital importance in the improvement of surgical outcomes, ultimately patient satisfaction, and the keratoconus can cause multiple sources of keratometric and biometric errors. Finally, this is a very nice book. We made it with Cosimo Mazzotta. In 1 year, we got more than 10,000 seller in 1 year also only, and it was a huge collaboration with more than 50 of the people doing keratoconus globally, and I encourage everyone to take this book. And this is the MIOM meeting, and the AIOS is already have an MOU with us in Dubai. We have last year, a lot of Indians were coming to Dubai last year, and a lot of speakers, and also young ophthalmologists were coming from India. So I encourage everyone to go through this and be with us this year also in Dubai. Thank you so much.
Thank you very much, Professor ARMIA. I think it was an amazing, great overview, and with your extensive work, you made it look very simple, but great pearls shared.